Hello, my name is KScheeler. I'm one of the pediatric cardiac sonographers here at Children's Hospital Colorado, and today I'm going to be discussing how to image Tetralogy of Fallot. Real quick, there might be some additional information on some of the slides that I'm not going to go to great detail about, but you can always access a PDF version of this if you'd like to review it later. Quickly, I have no relevant financial relationships with commercial interests. Okay, let's get down to business. Putting the tetra in tetralogy, the four defining lesions. First, you have pulmonary valve stenosis, then ventricular septal defect, then overriding aorta, and finally right ventricular hypertrophy. And the primary cause of the first three is the anterior deviation of the conal septum, which I'll get into more later. Here is a quick chart of the echo goals and key findings that you can always refer back to. All right, let's start with imaging. So these are the four defining lesions of Tetralogy of Fallot, which I mentioned earlier. Here you have your pulmonary stenosis. This is your VSD. Over here you have your overriding aorta. And finally, right ventricular hypertrophy, or RVH. All right, let's talk about the first lesion, pulmonary stenosis. So the severity of tetralogy exists on a spectrum, which is based on the degree of pulmonary outflow tract obstruction and the amount of pulmonary circulation. The cause, again, is the underdevelopment of the anterior malalignment of the conus or infundibulum, which creates varying degrees of pulmonary stenosis, which can also include RVOT obstructions. So, the less obstruction, the less severe, and similar to VSD physiology, think pink tet. And then the more obstruction, the more severe, up to including pulmonary atresia. Now, in severe cases of tetralogy, such as pulmonary atresia, blood flow is often supplied by the PDA and or MAPKAs, which I'll also get into later. All right, what are your echo goals with pulmonary stenosis? They are to determine the level of obstruction across the RVOT and pulmonary valve annulus and diameter, pulmonary valve morphology, MPA and branch diameters and velocities, PDA size and shunt direction if present, and you always want to use long, slow sweeps to identify your area of interest. Some of the best views for this, for 2D in color, are going to be parasternal long axis, like the RVOT view, parasternal short, and then you always want to use spectral Doppler in the RVOT, by the pulmonary valve, branch pulmonary arteries, and any other areas of stenosis. Now, one important point to remember is that assessing for pulmonary stenosis prior to repair is largely a 2D endeavor and less about Doppler velocities, as they can misrepresent the actual stenosis. And what I mean by that is that if you have a stenotic pulmonary valve, the flow from the right ventricle is actually going to cross the VSD and go out the aorta, and thus reducing the amount of flow and velocity across that stenotic RVOT or pulmonary valve, whereas the opposite is also true, where if you have a wide open pulmonary valve, a lot of that extra flow from the left side of the heart is going to course to the VSD and out the pulmonary valve, and increasing the flow and velocities. And here we have an example of a fixed versus dynamic obstruction. Over here on the left, you can see this is the pulmonary valve and this is the RVOT. Looks like there's some obstruction here. That is going to cause this dynamic Doppler waveform right here. And over here, you can also see that there's some obstruction in the distal to the pulmonary valve, and that's represented by this Doppler pattern here. Here's a couple different examples of pulmonary stenosis. On the left here, you have mild pulmonary stenosis, think pink tet. Over here, you have severe pulmonary stenosis, think blue tet. In mild pulmonary stenosis, this is going to have like a mild restriction, but will still allow blood flow to the lungs. And then in severe pulmonary stenosis, this may cause significant restriction of pulmonary blood flow. And then this restriction is going to lower the oxygen saturations of the blood and cause potential cyanosis. Okay, let's talk about pulmonary atresia, which is the most severe form of tetralogy. So in pulmonary atresia or severe TET, the pulmonary circulation is often provided by the PDA if present and or MAPKAs. You got two different types. Over here on the left, we'll talk about short segment, which is typically related to the valve. You have kind of an atretic plate-like pulmonary valve, and you can see that all the flow that's going out into the branch pulmonary arteries is coming up through the PDA. Now in long segment, this involves the MPA and or the branches, and they're typically hypoplastic to some degree. And the body's always going to try and compensate, so there's like this inverse relationship between the degree or size of your branch pulmonary arteries and the amount of MAPKAs. So the smaller your branch pulmonary arteries are, typically you're going to have more MAPKAs. And you can see here, this is kind of like in a modified suprasternal notch view, there's all these fireworks that you normally wouldn't see, and those are what MAPCAs look like. And the way MAPCAs work is they actually kind of come off randomly off of the aorta, could be almost anywhere, and then they travel straight back to the lungs, so giving blood supply, and then that, of course, will come back via the pulmonary veins into the left heart and out to the body. All right, next one, ventricular septal defect. So again, it's the anterior malalignment of the conal septum, which results in the failure of septation with the crest of the muscular septum, creating a wide communication between the ventricles rather than a deficiency. So it's kind of like, instead of assuming that there's tissue missing that causes the VSD, it's more like they just missed each other. The VSD is often characterized as an outlet VSD with or without paramembranous extension and with anterior malaligned outlet septum. The VSDs are typically large and unrestrictive. However, in a small amount of cases, you can get a restrictive communication, and that's almost always caused by accessory tricuspid valve tissue. What are the echo goals of scanning your VSDs? You want to determine the size and type of the VSD, the shunt direction, and you want to rule out additional VSDs. Real quick on that. Anytime you have an unrestricted VSD, blood is always going to go to the path of least resistance, so most of the blood cells are going to want to go out that unrestricted large VSD, such as we see right here and right here. However, there may still be additional VSDs that are maybe restrictive, and so what you need to do after your initial sweep is lower your Nyquist way down, maybe into like the 30s or 40s, and do an additional ventricular septal sweep, and that may bring out those additional VSDs, which can be helpful for surgical planning. Some of the best views for this are going to be parasternal long, like we see right here, parasternal short, right here, and then some alternative views could include apicals and subcostals. And now you always want to use your Dopplers to determine the shunt directionality and peak velocity. Okay, VSD morphology. So a couple different views here. You got the parasternal long view here and the parasternal short view here, just kind of showing you how to measure it. You always want to do your measurements at kind of 90 degrees to each other to get kind of a feel for the overall size of the VSD. Parasternal long is going to help you identify if there's any additional tricuspid valve tissue, possibly including the VSD, and parasternal short is really great for determining if there's a paramembranous extension and also evaluating the conus. Shunt direction. VSD shunting is typically related to the degree of pulmonary outflow tract obstruction. So the more stenotic atretic the pulmonary valve and or the pulmonary arteries, think downstream resistance, the more likely we're going to see right to left shunting. So these are two really good videos that kind of highlight that. You can see in this video here that there is flow leaving the left ventricle going out of the aorta, and also in systole from the right ventricle traveling through the VSD and out of the aorta. So that would be your right to left shunting. All right, next one, overriding aorta. So here we are again with the underdevelopment of the conus causes the aorta to move toward the right heart and override the ventricular septum. Now in severe cases of TET, the aortic valve and pulmonary valve relationship can be altered. By echo, we see this as a significant clockwise rotation, and it may also move anterior to the pulmonary valve. And then also the aorta is often dilated. Okay, what are your echo goals here? You want to measure the aorta, annulus, sinus, STJ, and ascending aorta. You want to determine the aortic pulmonary relationship and determine the aortic rotation and the coronary origins. Some of the best views here again are going to be parasternal long for your aortic measurements and aortic override, which is seen right here. And then parasternal short will help you determine the aortic pulmonary relationship and coronary origins and anomalies. Okay, clockwise rotation and pulmonary valve relation. So over on the left here we see mild TET outside of the pulmonary artery being kind of hypoplastic. You would expect, or you can kind of see that it looks very similar to what we would expect in parasternal short. However, over here we have severe TET. And now what's happened here is that there's a rotated AV pulmonary valve relationship, and the aortic valve has moved more anterior, being up here, and then here's the pulmonic valve, and more rightward. You can see it would possibly be causing some sort of obstruction here. Okay, clockwise aortic rotation and coronary arteries. So clockwise rotation of the aortic root by echo in TET often causes the origins of the coronary arteries to also be rotated. So if we look over here on this left-sided clip, this is the aorta right here, and typically we would expect the left system to come off kind of somewhere around here. However, in this rotated aorta, it's now coming off more posteriorly down here and shooting up this way. Now the same would be true for the RCA. We just don't have the color box up here. We would kind of expect it to be coming off somewhere around here. Again, because of that rotation, it most likely will be coming off somewhere in this neighborhood. Now there's also anomalous branching patterns that are reported in about 5% of tetralogy cases. And the most common is going to be the LAD that comes off the RCA. So in that case, the circumflex would just be coming directly off the left coronary cusp. However, you can also have what's called a dual LAD. So you would have one coming off the RCA and then another kind of coming off in the area that we would expect it to. And now, if you do have an LAD coming off the RCA, it's really important to determine this prior to surgery in the event that they're going to use a transannular patch. Because in a transannular patch, what they're doing is they're going to make an incision from the MPA across the valve and into the RVOT. And if there's an LAD coursing from the RCA leftward across that area, they could cut right through that coronary. And we can imagine that that's not real great. Just real quick, when you have an LAD off the RCA, it's not uncommon to have a very prominent conal branch, which is what we see right here. And I only bring this up because this could be mistaken for an LAD coming off the RCA. You just got to look a little bit harder. And lastly, we have right ventricular hypertrophy, or RVH. RVH is often secondary to the other three lesions. The unrestricted VSD and pulmonary stenosis create equalization of pressures across the ventricles, resulting in the right ventricle pumping against systemic afterload pressures. And that then, of course, results in hypertrophy, which you can see right here. Okay, RVH echo goals, they're pretty simple. You just want to assess the degree of RVH for multiple views and diastole. So some of the best views are going to be apicals, like apical 4 with an RV focus, apical RAO, which I'll show you in a minute, and then subcostals, kind of a coronal view with an anterior tilt for the RV free wall, and then of course peristernal short's always great, base level, papillary level, etc. And you can see that this has some obvious hypertrophy here in the right ventricle. Here's just a couple more views. We've got some hypertrophy shown in peristernal short. This is that subcostal view with an anterior tilt showing the right ventricular free wall. And this is actually like my favorite view. I didn't even know about it until I got into peds. This is called apical RAO. So the way you get here is you basically start like in an apical 4, rotate up to 1 o'clock and kind of move a little medial, kind of pan back and forth. And the goal here is that you're going to find the right atrium, tricuspid valve, right ventricle, RVOT, can't see it well here, but pulmonary valve, MPA, and sometimes the branches as well. Super great view with a lot of information, and you can see hypertrophy here as well. Okay, let's talk about the repairs for Tetralogy of Fallot. There's basically two main goals. The first is the isolation of the right and left heart systems, and then restoration of adequate pulmonary blood flow from the right ventricle to the lungs. Down below here is a handy little chart you can use to assess for the degree of pulmonary stenosis by velocity post-repair. Okay, let's talk about isolation of the right and left heart systems. A VSD patch is placed from the ventricular septum to the overriding aorta, separating the left and right hearts and incorporating the aorta into the left heart only. Now your echo goals here are going to be to sweep through that VSD patch and interrogate for any residual leaks. In this video here, it actually shows a patch leak right here, and if a residual shunt does exist, then you want to use spectral Doppler to capture the directionality and velocity. One other pro tip here, once the unrestricted VSD is patched and closed, there may be other restrictive VSDs that weren't seen prior that all of a sudden are visible, and you want to then do additional VSD sweeps across the entire ventricular septum to look for those additional VSDs that may have popped up. Okay, so let's talk about restoration of adequate pulmonary blood flow. And the first thing we're going to discuss is the valve sparing technique. This is the preferred method. It's a surgical procedure. It has improved long-term outcomes, and it's designed to preserve the native valve and reduce stenosis, often using a valve dilator or valvotomy. In addition to this, they're going to want to eliminate any sub or suprapulmonary stenoses, and this can be done in a few forms. You can do it by doing an RVOT muscle resection in this area. You could place an RVOT patch right up in here too, and the purpose of that is to kind of widen out that area. You could also do an MPA patch, and that would be done over here, again for the same purpose. And in the process, they're going to do their best not to mess with this valve. What are your echo goals here? So first you want to interrogate the valve for function using 2D, And then you want to interrogate for stenosis and regurgitation across the valve using color and spectral Doppler. You also want to interrogate any other sites of previous stenosis, such as the RVOT, MPA, branch PAs, using color and spectral Doppler. Now, real quick here, this is post-repair. It's probably still hypoplastic, which is normal because they left the valve alone. And you can see here that we still have some accelerated flow at about 1.7 meters a second. And again, that's because this valve may still be mildly hypoplastic after the repair. All right, next one, transannular patch. This is also a surgical procedure. It's used when the pulmonary valve and annulus are too small for a valve sparing technique. It's designed to increase diameter for adequate pulmonary blood flow. What they do is they make an incision across the MPA, the valve, and into the RVOT, and then they place this big patch here. And in the process of doing that, they're going to end up destroying the valve. So some of the complications for this can be free regurgitation, which is typically well tolerated for years and can often be a bridge to a pulmonary valve replacement around 8 to 15 years of life. Echo goals here, you want to interrogate the patch region for stenosis and free regurgitation using color and spectral Doppler. You want to interrogate other sites of previous stenosis, such as the RVOT, MPA, branch PAs, using color and spectral Doppler. And this is a really great video showing that free regurgitation. This is where the pulmonary valve was, and you can see the antegrade flow coming in here, and then immediately you can see the retrograde flow as free regurgitation here. And this is how it would look on a Doppler. This is your free regurgitation, and this is your normal antegrade flow. Finally, we got the RV to PA conduit. This is also a surgical procedure. It's used in cases with pulmonary atresia and or severely hypoplastic or absent MPA. It's designed to create a pathway from the right ventricle to the MPA or branches for pulmonary blood flow. This can be a valved or non-valved conduit, and complications include conduit stenosis, endocarditis, and possible reoperations. Echo goals here, similar to the others, you want to interrogate the conduit and valve, if applicable, for stenosis and regurgitation using color and spectral Doppler. You want to interrogate other sites of previous stenosis, such as the RVOT, MPA, branch PAs, using color and spectral Doppler, and interrogate the conduit and valve for endocarditis and thrombus. Here are my references. Finally, I want to thank you very much for attending my discussion on how to image Tetralogy of Fallot. There's going to be a Q&A at the end of the tetralogy discussions where I'll be present. If you have any questions, you may also email me at the email below. And thank you again, and have a wonderful day.